Measles. The skin lesion in measles is an erythematous maculopapular blanching, partially confluent exanthem. Summary: Measles is a highly infectious disease that is caused by the measles virus. There are two phases of disease, a catarrhal stage and an exanthem stage. The catarrhal stage is characterized by a fever with conjunctivitis, coryza, cough, and pathognomic Koplik spots on the buccal mucosa. The sudden development of a high fever, malaise, and exanthem represents the next phase. The exanthem stage is typically characterized by an erythematous maculopapular rash that originates behind the ears and spreads to the rest of the body towards the feet. Infection is usually self-limiting and followed by lifelong immunity. Disease management includes vitamin A supplementation, symptomatic treatment, and possible post-exposure prophylaxis. Measles cause transient immunosuppression and may lead to serious complications such as encephalitis, otitis, or pneumonia. A rare but lethal late complication of measles is subacute sclerosing panencephalitis, which may also affect immunocompetent individuals. The prognosis is good in uncomplicated cases; however, newborns and immunocompromised patients are more likely to suffer from severe complications. The measles vaccine is a combination vaccine that protects against measles, mumps, and rubella. The measles, mumps, rubella, varicella vaccine also protects against varicella. Immunization is recommended for all children in addition to adults without evidence of immunity to measles, mumps, and/or rubella. Epidemiology of measles. Peak incidence. Peak incidence of occurrence of measles is less than 12 months of age. Infectivity. Measles is highly contagious 4 days before and up to 4 days after the onset of exanthem. The disease is most contagious prior to the onset of exanthem. Etiology. Pathogen which causes measles is measles virus. Route of transmission is through direct contact with measles virus or inhalation of virus-containing droplets. Clinical features of measles. Incubation period of measles after infection is of 2 weeks duration. There are 3 stages of measles: prodromal stage, exanthem stage, and recovery stage. Duration of prodromal stage is 4 to 7 days. Presentation: coryza, cough and conjunctivitis, fever, temperature greater than 40 centigrade or possible in fever, Koplik spots. These are the features of prodromal stage. Koplik spots are pathognomic enanthem of the buccal mucosa, tiny white or bluish-gray spots on an irregular erythematous background that resembles grains of sand. These are white necrotic tissue which typically develop next to the first molars and cannot be scraped off with a spatula. Koplik spots disappear by the second day of the exanthem stage. The absence of Koplik spots in measles does not exclude measles as a diagnosis. Exanthem stage. The duration of exanthem stage is 7 days, develops 1 to 2 days after enanthem. The features of exanthem stage are high fever and malaise, generalized lymphadenopathy, erythematous maculopapular blanching, partially confluent exanthem. Fever typically resolves 4 days after the onset of the rash. Persistent fever suggests a complication. Maculopapular exanthem begins behind the ears along the hairline. It disseminates to the rest of the body towards the feet. Palm and sole involvement is rare. It fades after 5 days of onset, leaving a brown discoloration and discoloration in severely affected areas. Exanthem is confluent on face and trunk, less so on extremities. Recovery stage. In the recovery stage, the cough may persist for another week and may be the last remaining symptom. The most important findings of measles are the 3 Cs and 1 K: coryza, cough, conjunctivitis and coplic spots. Coryza is rhinitis. Measles fact sheet. Coplic spots. Coplic spots, which are characteristic of measles infection, are visible on the buccal mucosa. These are white necrotic lesions on an erythematous base. Measles rash, generalized maculopapular exanthem, is visible on this toddler's body. Abdominal rash in measles, a widespread maculopapular rash is visible across the abdomen. Multiple maculopapular blanching and partially confluent patches are disseminated over the head, neck, and back of this young patient. These findings are consistent with idiopathic rash, which can occur after fading of the first erythematous exanthema caused by an infection with the measles virus. A maculopapular erythema which is partially confluent is visible on the trunk. In combination with the corresponding characteristic clinical features, these skin findings are suggestive of measles. Measles maculopapular rash. Diagnostics. Measles should be suspected in a patient with typical clinical findings. Lab tests are always necessary to confirm the diagnosis. CBC, decreased leukocytes, decreased platelets, serology, gold standard, detection of measles-specific IgM antibodies appear at the onset of exanthem but may be negative within the first 3 days of infection. False positives may occur with other viral infections, for example, parvovirus B19 infection or rheumatoid factor IgG antibodies. Identification of pathogen, direct virus detection via reverse transcriptase, polymerase chain reaction possible. Biopsy, affected lymph nodes show paracortical hyperplasia and Warthin-Finkelday cells, multinucleated giant cells formed by lymphocytic fusion. Treatment Treatment is symptomatic, no antiviral therapy available. Vitamin A supplementation reduces morbidity and mortality, especially in malnourished children. Isolate patients with confirmed infection. All patients isolate for 4 days from the onset of rash, longer if immunocompromised. Individuals who are immunocompromised are contagious throughout the course of the disease as a result of prolonged viral shedding and therefore should be isolated for the duration of their illness. Hospitalized patients initiate airborne precautions. Complications: subacute sclerosing panencephalitis. Bacterial superinfection can lead to otitis media, pneumonia, or laryngotracheitis. Pneumonia is the most common cause of death in measles patient. Gastroenteritis, meningitis, acute encephalitis. Acute encephalitis often results in permanent neurological deficits. Complications are likely to occur when the fever does not subside after a few days after onset of exanthem. Prognosis: The prognosis of measles infection is good in uncomplicated cases. Fatal courses are more likely in newborns and immunocompromised patients. High fatality rate in resource-limited countries due to secondary bacterial infections. Prevention. Vaccine. Available options are live attenuated vaccines that contain multiple antigens, measles, mumps, rubella vaccine, measles, mumps, rubella, varicella vaccine. Contraindications to vaccines are any contraindications to live vaccines, history of anaphylaxis from neomycin, MMR and MMRV both contain neomycin. Precautions: history of thrombocytopenia, tuberculin skin test within the preceding 4 to 6 weeks. Live vaccines can interfere with the interpretation of the TST. Personal or family history of epilepsy. MMRV vaccine only. In children less than 24 months of age, the MMRV vaccine is associated with an increased risk of post-vaccination seizure. The MMR vaccine is contraindicated during pregnancy. Individuals without evidence of immunity to MMR should receive 1 dose of MMR after delivery, preferably before discharge from the healthcare facility. Individuals with HIV and CD4 percentage greater than 15% and CD4 count greater or equal to 200 cells per millimeter cube for greater or equal to 6 months and no evidence of immunity to MMR should receive a two-dose series of the MMR vaccine administered 4 weeks apart. Live vaccines are contraindicated in individuals with severe immunocompromise, that is CD4 percentage less than 15% and CD4 count less than 200 cells per millimeter cube. Healthcare personnel with no evidence of immunity to MMR should receive a two-dose series of MMR vaccine administered 4 weeks apart. Post-exposure prophylaxis for measles indication: negative or indeterminate serological immunity. Methods: active immunization for immunocompetent individuals after direct exposure prevents disease onset or shortens symptom and infection duration, ideally administered as one dose of the MMR vaccine. Passive immunization for immunocompromised individuals, administration of measles immunoglobulin within 6 days of exposure. Further measures for exposed individuals: avoidance of communal facilities, recommended for a minimum of 14 days. Thank you.